and welcome to today's edition of Petcast. Today is August 28th, 2024, and I'm Rifat Manan in California. Today, we are very delighted to welcome back Dr. Genevieve Crane, who is staff hematopathologist at Cleveland Clinic Foundation, and she is also the associate professor of pathology at Lerner School of Medicine. Did I pronounce it right? At Cleveland Clinic. Yeah. And she is back with us, and she had delivered lectures on our platform earlier, and we really appreciate Dr. Crane. And today she will continue with her hematopathology lecture series, and this would be the 9th lecture in the series. And we want to again shout out Dr. Orbach for helping us and organize this lecture series. Thank you, Dr. Orbach. And today, Dr. Crane is going to talk on post-transplant lymphoproliferative disorder and the recent changes in the entity. So the title of her talk today is PTLD and immunodeficiency associated lymphoproliferations. And thank you, Dr. Crane, for joining us today. Over to you now.
Thank you so much. I'm very honored to be back on Pathcast and talking about a topic that's very near and dear to my heart and really kind of inspired me in part to go into hematopathology. So I'm just going to turn off my camera so you can focus on the slides here. There we go. But yeah, focusing on post-transplant lymphoproliferative disease and other immunodeficiency associated lymphoproliferations. So a quick overview of what I'll cover today. First, looking a bit more at Epstein-Barr virus and its strong association with many types of lymphoproliferative disease in this setting, the morphologic subtypes, which we still recognize, kind of a little bit more of a historical perspective and how our nomenclature has changed with the 5th edition WHO and the standpoint also from the ICC. Then looking a bit more broadly, the context of lymphoproliferative disease and how it associates with immune deficiency and dysregulation. And finally, again, a bit more on that revised nomenclature and how this can really, I think, be impactful in terms of understanding these disorders going forward. So just a brief summary of kind of what PTLDs are, this post-transplant lymphoproliferative disease. Essentially, we see an increased risk of lymphomas as well as lymphoproliferations that don't necessarily qualify as a monomorphic lymphoma that we would see in an immune competent patient following either hematopoietic stem cell transplant or solid organ transplants. And these are often EBV associated, particularly in that very early transplant period. And the risk of these has been well studied, and it can be affected by multiple factors. These include both the degree as well as the type of immune suppression. More severe immune suppression results in an increased risk. The type of transplant, for example, thoracic, cardiac, and lung transplants have a higher risk than does a kidney transplant. The amount of time, as I mentioned earlier, is also important. That's elapsed since transplant. That early transplant period is the highest risk, those first 6 months. And also the EBV status. If a patient has not been previously exposed to Epstein-Barr virus, then they're at increased risk of developing a lymphoproliferative disease, particularly should they receive a donor organ that is positive for EBV. But this field is not static, and in fact has been changing ever since transplants began, have begun essentially because of the advances that we have and the refinements that we have in immune modulation. And we'll discuss that a little bit more as well. These lymphomas and lymphoproliferations are predominantly aggressive in nature, but not all. And several indolent forms are now also recognized, as well as some with kind of a medium potential. And also, as the WHO is more formally recognized, but has been in prior editions of WHO, and of course is also covered in the ICC, is that these medications that we give to transplant patients are being used more broadly. And there are a lot of them also emerging, and kind of how we modulate the immune system is really changing over time. And particular patients may be having particular risks of individual types of lymphoproliferations. And we get an overlapping spectrum of lymphoproliferations in different settings, from HIV to inborn errors of immunity to autoimmune patients who are treated with various immunosuppression agents to the PTLDs, which are best well studied and we'll focus on initially. So just a little bit about the nomenclature change, because that is kind of the sort of elephant in the room, that there has been kind of a revision to the standardized nomenclature for these entities in the 5th edition of the WHO. And this is kind of something that's been long recognized, but is more formally incorporated into the WHO, where we're now going to have a more standard way of not just saying, here's a chapter on PTLDs, here's a chapter on HIV-associated lymphoproliferations, here's a chapter on methotrexate, but instead say, a lot of these things do show overlapping morphologies. Let's have a standard way of showing them that, for any sort of setting of immune deficiency and dysregulation. Now they recommend using a 3-part diagnosis where you're going to say, what is the morphologic phenotype of what's going on? Do we have a hyperplasia? Do we have something like an Epstein-Barr virus mucocutaneous ulcer? Do we have something that's diagnostic of lymphoma, irregardless of the clinical context? So that's your first part, which is something that we do, of course, had been doing, of course, anyway. Then, specifically mention whether or not there's any viral association. And finally, specifically call out the immunodeficiency setting, which of course we have done in the setting of post-transplant, but now saying, more broadly, we need to look into the clinical charts, look into the clinical history and see, does this patient have any other cause for immune deficiency that we may want to be aware of and formally document in the diagnosis. And so because post-transplant has been the most well-characterized, we're going to begin a discussion kind of with that viral association that we've seen there and the morphologic subtypes that we have that have been previously characterized in PTLD. So Epstein-Barr virus, one of most commonly seen herpes viruses, and infects greater than 95% of adults, are kind of the common numbers that you hear. The herpes virus family contains overall more than 100 known viruses, but only around 8 of them are routinely infecting humans. And when we think about immune suppression related lymphoproliferative disease, we're thinking about only a subset of them, predominantly the gamma herpesviruses, Epstein-Barr, and Kaposi sarcoma herpes viruses, because of their ability to infect and their tropism for B cells, and also their latency state, which after people recover from an infection with one of these viruses, you end up having a latent reservoir of herpes viruses in your body, and that latent reservoir is in B cells for both EBV and Kaposi sarcoma. In human herpes virus 6, which is also of interest, although not as well documented, having a role in lymphoproliferative disease in this setting, remains latent in T cells. So kind of thinking about now why, in addition to just kind of being harboring in B cells, Epstein-Barr virus is actually extremely potent in terms of immortalizing B cells. And in fact, makes all sort of products that alter B cell metabolism, survival, proliferation. These may depend on the latency state, but certainly in the lytic state and in that initial infectious state, you can actually transform your own circulating B cells into a cell line for study. So it's pretty interesting. But if that's not kept under control by an intact immune system or adequate immune system, you'll just get runaway growing B cells from EBV. So it's that potent. So that's kind of why we see these EBV-driven proliferations in the post-transplant setting, where T cell response, the normal T cell response, has been diminished in order to prevent organ rejection. And of course, the more severe that loss of T cell control is, the more likely someone may be to develop have reactivation or poorly control an initial infection with EBV. And of course, those patients, as I mentioned, with the new infection are at greatest risk in that post-transplant setting. Okay. So it's actually quite interesting, and there's some active research in this area as well, kind of thinking about what are the special things that EBV does when it infects a cell, and can we actually, potentially develop novel ways to target that for therapy for these disorders. And we can imagine that when a virus infects a cell and its mission is to just kind of make more viruses and have that initial lytic cycle, sure, it's going to hijack the cell metabolism and take over, all of the building blocks of the cell to make its own virions. But it turns out that, even if you have a lytic state, or even if things are kind of in the steady state where very few viral proteins are expressed, it actually also does alter the host cell metabolism even in that setting. And the ways that it alters it are actually not so dissimilar from kind of these metabolic hallmarks of cancer that we also see described. We have an increase in glycolysis and an increased use of these intermediates for various biosynthetic pathways and NADPH production. And they may alter signaling in the cell, DNA methylation, cellular differentiation, with, in fact, also mitochondrial biogenesis being one of the byproducts of EBIT2, which is one of the EBV-associated proteins that's produced in the latency state. And I don't want to make anybody go to sleep at this point in the talk, but it is pretty interesting to look at kind of the different potential oncogenic roles of different EBV products. And these are products that are made by EBV in the latency state. And particularly, we can look at, for example, LMP1, which is expressed in virtually all EBV positive. It should be expressed in all EBV positive plastic Hodgkin lymphoma. And that can basically mimic cellular CD40 to activate the NF-kappa B pathway, and also affect other downstream pathways involved in both glucose uptake and glycolysis, and essentially help drive tumor growth directly through that surface membrane protein that's made by EBV. And ABNA2, as I mentioned, is often expressed in polymorphic PTLDs that have a broader latency pattern, and those will mimic cellular notch signaling and as well as regulate MYC and also lead to mitochondrial biogenesis and activate metabolic pathways in that regard. And so this is kind of the latency states here, which again, just for your reference, and this is from a paper that I worked on a few years ago, where we can look at these latency states, and that can tell you a little bit about, not only be useful from a diagnostic standpoint, but also to think about what is EBV doing in these B cells to help drive this lymphoproliferative process. And as we have decreasing T cell control, we tend to have more viral genes expressed. And so this can help us from a diagnostic standpoint of saying, oh, this is more likely a polymorphic PTLD. We have all of these genes expressed, but potentially this patient could benefit from restoration of the immune system to combat this, rather as a first try rather than necessarily chemotherapy. So that's that summary there. And you can see they kind of vary in different diseases. For example, Burkitt lymphoma typically occurs when patients have more of an intact immune system, even in the setting of HIV, and these have very few latency genes expressed. So post-transplant lymphoproliferative disease is one of the first complications that was really noted once people were finally able to perform a successful solid organ transplantation. Technically, it became possible to do allogeneic kidney transplants in the 50s. For example, you had transplants being performed between identical twins, one of the early studies coming out, but it really took until adequate measures of addressing the immune response could be successfully carried out before you could have allogeneic transplants. And this was really kind of made possible in the 60s with the discovery that azathioprine, when you use it together with steroids, that you could actually successfully have an organ survive for a significant period of time when transplanted to a new patient. And these studies, even the first few studies coming out in the late 1960s, we saw that post-transplant lymphoproliferative disease was the most common, one of the most common adverse outcomes. Interestingly, these lymphoproliferations that happened in those really early cases were very often involving the brain. In fact, in one of the initial series, 13 of 25 cases involved the brain, and 11 of them were only in the brain. And this is quite unusual because normally CNS lymphomas are rare, as you may have seen on service. We did also note that we saw an increase in them in the AIDS epidemic before we had adequate heart therapy as well. These were like 1,000-fold increase in the setting of HIV/AIDS, unfortunately, as well. And so that's kind of the background. But now we know that we kind of, they're not just affecting the brain, they're maybe not just aggressive. We see kind of like a whole spectrum here. So we have some that are non-destructive. This is an example of a tonsil that we see here, where you see kind of like follicular hyperplasia. These need to be EBV positive. The non-destructive type, you have polymorphic that show a mixed population are characterized by tissue destruction. So that's why we have non-destructive. We have destructive type, And then we have things like diffuse large B-cell lymphomas or plasmablastic lymphomas, other things that would be diagnostic of lymphoma in any context, irregardless of that transplant history, and look morphologically similar to those seen in immune competent patients. And then finally, we have classic Hodgkin lymphoma, which is really kind of a subtype of monomorphic, and these need to very carefully follow the diagnostic criteria for classic Hodgkin lymphoma. All right. So focusing a bit more on the non-destructive type first. These can come in multiple kind of flavors, but what you should have is some sort of EBV-driven lymphoid hyperplasia that's within an overall intact tissue structure. As you can see here, a couple examples. This one's from Dr. Gong, which was submitted as part of the Society of Hematopathology education material. It's actually on Twitter. You can find it there or on their website. And this is one from Dr. Chadburn, showing just kind of, it doesn't look that bad. You kind of see like, it looks okay, you got some reactive follicles here, but we've got retention of the tissue. But you should have some mass formation. But they're commonly in places like lymph node, tonsils, adenoids, and it's really only diagnosable as a post-transplant lymphoproliferative disorder if you've got EBV positivity. In the absence of that, you essentially just have kind of a florid follicular hyperplasia. There's also a subset that's kind of termed infectious mononucleosis. Like these patients should have no prior document of EBV positive infection. So it's kind of a florid, kind of initial reaction to that initial EBV infection that's less poorly controlled compared to immune competent patient, but doesn't quite reach the level of polymorphic PTLD. It's a little can be a little bit challenging to diagnose. And then plasmacytic hyperplasia, these should be polytypic and then also EBV positive is how they can be defined. And of note, if patients have suppressed immune system and they have lymphoproliferations in one site, you may actually have lymphoproliferations in multiple sites that may be unrelated. So you could have, some sort of other destructive PTLD that's occurring somewhere else in the same body. So they're not necessarily all connected, and potentially may need to sample multiple sites or the most PET avid site to have the appropriate diagnosis. And both these follicular hyperplasia and I should say FH, sorry. Follicular hyperplasia and infectious mononucleosis type proliferation are more common in children. So just briefly, polymorphic PTLD. Now, these are something that are pretty much seen only in immunosuppression related settings. We now recognize, as we'll see, that these polymorphic PTLDs can occur in multiple different types of settings. For example, in the setting of methotrexate, in the setting of HIV, and we didn't really have a way to categorize them or kind of diagnose them until the revisions to the WHO 5th edition and the ICC. Now both recognize that these polymorphic proliferations can occur across immunosuppression related settings. And these are important to recognize because they may actually respond, a subset of them may respond to reconstitution of the immune system, but they can be aggressive and result in significant tissue destruction and obliteration. And in fact, that's required for diagnosis. So these can be seen in various sites: lymph node, tonsil, GI tract, liver. I've even seen them in the CNS and bone marrow. They can occur basically anywhere. And the patient can have significant systemic symptoms such as HLH or EBV viremia. It's also often detected. These are very common in that early transplant period. The first year, first 6 months is when you would most commonly see polymorphic PTLDs. And one of the most important things for diagnosis to think about is that you don't have a sheet of monomorphic B cells. You've got all kinds of different cells going on. You have a full range of B cell differentiation. You have variable size lymphoid cells. You've got plasma cells. You've got immunoblasts. You probably have generally do have some Hodgkin-Reed-Sternberg cells that look sort of like Hodgkin-like, but there's a whole lot more B cell differentiation going on there. And importantly, to kind of distinguish, even though obviously you have a mixed inflammatory environment, oftentimes in classic Hodgkin lymphoma as well, you're going to have EBV in the setting, and it's going to look like this, where you've got these, not just the Hodgkin-Reed-Sternberg cells that are EBV positive, as you would see here, but all these other cells. And so you have a kind of a range of lymphoid cells that are expressing EBV, and it's not just exclusive to those Hodgkin-Reed-Sternberg cells. In addition to that, in classic Hodgkin lymphoma, you're going to see the Reed-Sternberg cells are expressing the EBV LMP1 that we talked about. They're not going to express EBNA2. They're just going to restrict themselves to that one latency protein that we typically measure, but you're not going to see a broader range. And in polymorphic PTLD, they're going to be EBV related. You're going to see kind of a broader range of EBV associated antigens, with usually seeing both LMP1 as well as EBNA2. And then in all of these cases, you're going to see EBER by in situ hybridization. And so it can also be difficult to distinguish from infectious mononucleosis like PTLD. Having a prior history of EBV infection can also help with that. In some instances, you may have a larger resection, and some areas look like this. Some areas look like maybe you are getting a little bit more of a monomorphic proliferation. That can happen without excluding the diagnosis. But again, these become sort of a judgment call of whether or not maybe it has transformed to a true monoclonal proliferation. But typically it should be more necrosis and a mixed inflammatory picture like that. The next subtype that we can see, which of course I didn't include in that initial image, but we also consider this in the spectrum of, could be in a post-transplant, but also in any sort of immune suppression related setting with age, chemotherapy, other types of immunosuppressive medications, is the EBV mucocutaneous ulcer. So these have a very characteristic appearance. Usually you don't get lucky enough that you actually get a nice deep biopsy, but if you do, you'll see that it's kind of sharply demarcated mucosal lesion or skin ulceration that has at the base of the lesion a very sharply defined rim by reactive T cells. These are EBV associated, but like in contrast to someone that has systemic symptoms and has more of an aggressive process or a polymorphic PTLD, you're not going to be detecting that EBV viremia. You're not going to be getting that EBV DNA in the peripheral blood in general in these cases. It's just kind of isolated to this lesion that should be sharply defined. And these have a much better prognosis and are generally self-limited. A patient also shouldn't have significant other systemic symptoms or lymphadenopathy in the context of these EBV mucocutaneous ulcers. But if you just get a tiny biopsy and you really don't have that whole context, it can be very challenging to make the right diagnosis unless you have that, put that whole clinical picture together. Now, monomorphic PTLDs, these are actually the most frequent subtype. This is an example of one involving the GI tract that was EBV negative. These are typically genetic driven rather than, being driven primarily by viral reactivation, but primarily driven by additional genetic events, even if they do also have EBV association. And they can be of B cells, T cells, NK cells, anything that we would normally say is a lymphoma in an immune competent patient, with some caveats, which I'll get to. But these typically will not regress with just immune restoration. So the person will actually need typically chemotherapy. So it's important to distinguish this, not just write PTLD at the top. We need to know kind of what type morphologically to help direct therapy. And these tend to occur later post-transplant as compared to polymorphic, but can typically after the first year. The most common subtype of these, as with lymphomas in general, with aggressive lymphomas in general, is diffuse large B-cell lymphoma, accounting for around 50 to 75% of cases. In adults, EBV negative DLBCL PTLDs often show mutated TP53. And in this case, in fact, did have a significant TP53 mutation. And you can see here also strong nuclear staining with an IHC against P53 also hinted that that was going to be found. And this was from a nice paper from Elizabeth Corville going back to 2016. So other specific subtypes that are important to identify in this setting include, of course, Burkitt lymphoma, which requires a distinctive treatment and can be seen across immune suppression related settings, but is most common in the setting of HIV compared to the other ones. Classic Hodgkin lymphoma is also relatively less common in the post-transplant setting, around 5% of cases, although very common in the setting of HIV, irregardless of whether or not the patient has received heart therapy. It's important to note that in the post-transplant setting in particular, as I alluded to earlier, it's really necessary to be more sure of that diagnosis by requiring strict adherence to immunophenotypic criteria. These Reed-Sternberg cells can kind of be everywhere. There can be some in a DLBCL. They're certainly in the polymorphic. And so to really think about being a classic Hodgkin lymphoma for appropriate therapy, you want that EBV to be restricted to the Reed-Sternberg forms. Now, most of these PTLDs and immunosuppression-related LPDs we think of as being aggressive processes, and classically they are aggressive. However, we already saw that the EBV-positive mucocutaneous ulcer tends to have a very indolent course. Small B-cell lymphomas had typically been excluded, but we do now recognize that EBV-positive marginal zone lymphomas, particularly MALT lymphomas, but some of them are also nodal marginal zone lymphomas, are recognized as of the 4th revised edition and continue to be recognized, potentially a subset of EBV-negative. Also could be transplant related, although that's not formally recognized yet. Other things like CLL, SLL, follicular lymphoma are not typically recognized, even though patients may develop these lymphomas. They do not appear to be at a significantly increased risk or necessarily associated that we know of yet with that immunodeficient state. So PTLD, kind of moving on to kind of the next area, kind of thinking about where we were, where we're going, how these processes are evolving, and maybe how we can better ultimately serve patients with these. We know, as I mentioned, that kind of the immune suppression regimens have changed over time. Those initial regimens that really made transplant possible, that arose in the 1960s, used azathioprine and steroids. Subsequently, in the 80s, we had the introduction of cyclosporin and then subsequently tacrolimus, which are calcineurin inhibitors. And we found actually, even with the switch, that maybe there's potentially a little bit less immune suppression used with cyclosporin. We actually really didn't see a change. This is kind of a comparison that was published previously, looking at it's almost identical kind of the years post-transplant. You're getting a very similar incidence of PTLDs regardless of cyclosporin versus steroids plus azathioprine. But interestingly, and as anyone who may have been on clinical service may note, that kind of the site at which these things arise, we didn't see CNS disease that often, but we saw more often PTLD being in the graft itself, the GI tract, or as disseminated disease. So it's kind of like a shift potentially occurring, even though we had the same incidence. And this is some data that I pulled a while back when I was at Johns Hopkins, kind of looking at the trends over time. These are total number of cases. And of course, as more transplants are performed, we're getting more cases. But we saw kind of initially in kind of the cyclosporin era, almost all of them were outside of the central nervous system, very few cases. And then as other drug regimens started to then appear, for example, with the introduction of mycophenolate in 1995, we started to see creeping up, and also calcineurin sparing regimens, we kind of saw the CNS cases creeping back up again in the mid-2000s, mid to late 2010s. Those were coming back. And this is a graph here just to kind of show you the risk depending on what transplant people receive. Now, this kind of a complex system where, of course, the vast majority of transplants that are done are kidney transplants, because we're able to get 2 from a deceased donor, and then people can also have living related kidney transplants. So these are done much more frequently than other types of transplants like heart, lung, certainly liver, pancreas, intestinal transplants are only done very rarely. But we see that even though the vast majority of our transplants may be kidneys, this number is way down in terms of the cumulative incidence of PTLD. Those people tend to have fewer incidents as opposed to someone who receives a heart-lung transplant. But interestingly, the site also matters, because that's the majority of cases were arising outside the CNS. Renal transplants are underrepresented, maybe liver, maybe overrepresented, but in CNS cases, the renal transplants were actually overrepresented. They're actually renal transplants were more commonly gave rise to primary CNS PTLD, even than the frequency of them within the population. So it's not just a simple matter of saying, okay, you're at risk, you have this transplant. You know, it's definitely a complex thing with individual people, what medications they're on, the timing from transplant, the type of transplant, and probably other factors which we just don't know yet. Looking at the EBV association as well, you can kind of see in this early post-transplant period, percent of EBV positive cases in the brain, it's always 100%, which is also very interesting. But outside the brain, you see that this kind of declines with time from transplant. First year, vast majority EBV related. By 10 years, only around 20% of these transplant related PTLDs are EBV related. And that also varies with the morphologic type. We can see large B-cell lymphomas are typically what we see in the CNS. These are always EBV related in the CNS, although looking at the non-CNS cases, we're seeing this polymorphic type are pretty much the one are expanded in terms of EBV related and very infrequently EBV negative, where we see a larger fraction of the large B cells and other types being EBV negative as we look at the outside CNS cases. And this is data just kind of also showing you how common these disorders are from the United Network for Organ Sharing. This is data that was pulled around, I think through 2014, around there. Around 600,000 patients are in that database. It's de-identified and freely publicly available by that point. And we found around 7,000 documented cases within that data set. So around a 1.2% incidence pulling that data. And you can see of these that were documented, unfortunately, a very high mortality rate of 50 to 60%, depending on site, which is frequently actually not documented in this data set. So it remains a significant problem, regardless of where, brain or outside the brain, where these sites, where these occur. And this is just an example. This is from Cornell. Eber in one of the CNS cases, showing that in the primary CNS, as opposed to other sites, potentially related to immune-driven loss of EBV, that it may be important for initiation, but not maintenance of the tumor. But in the brain, you don't have that immune drive as you would in the periphery to lose EBV. And so that may explain that, in fact, a lot of these EBV negative cases, although we can't prove it yet and we don't know yet whether or not a lot of the EBV negative cases that we see outside the CNS may actually be sort of hit and run EBV cases, where it was important for initiation but not maintenance of the tumor. And so this is just some more data that we have here showing like why these cases may arise in particular sites. And again, we saw like kind of with the introduction of cyclosporin following the initial azathioprine data that we kind of lost all of our CNS cases. And indeed now they started to come back once cycloneurin sparing agents were used. And this is data from Hopkins showing that around 94% of cases were actually EBV that were in the brain were actually mycophenolate associated, which is hard to say because they're also on a number of drugs. But I will show you, this is a regression analysis, logistic regression analysis that was performed, showing that indeed kind of all these factors kind of affect where different PTLDs will arise, with mycophenolate being associated with CNS disease very strongly, and calcineurin inhibitors, actually tacrolimus and cyclosporin, were actually protecting the brain from developing PTLD. So kind of interesting findings that's not just solely related to immune suppression alone, but other factors. And liver or thoracic transplants were actually protected also from getting brain lymphomas. And this could be due to the fact we hypothesized that cyclosporin, because of its extreme hydrophobic nature, it's very lipophilic. You can kind of see this here. It's kind of extremely crazy lipophilic molecule. It does get very high and steady concentrations in the brain. We also know that it can act directly on EBV and prevent lytic activation. So maybe prevent viral spreading within that site. So now getting out kind of this broader picture of not just looking at PTLDs, but what about, if mycophenolate is having an effect on increasing the rate of brain lymphomas in post-transplant patients, what about the larger population of patients who have treatment with the same thing for various autoimmune disorders? And in fact, this is a patient who had eosinophilic granulomatosis with polyangiitis, who had been treated with mycophenolate and steroids with good control of her disease and had been doing quite well for about 10 years. Then she presents with ataxia, slurred speech, and multiple CNS lesions, one of which is shown here. None of them were terribly accessible, but we did get the small biopsy here, which you can see kind of these Reed-Sternberg-like forms and kind of a mixed background here in the brain. They're positive for CD30 and DIM-PAX5. And we see these Hodgkin-like cells, but it's like basically has these kind of Hodgkin-like lymphoproliferative disorder, part of more of a polymorphic picture that we're seeing in the brain, because we have that EBV reactivation in the background as well as in these Reed-Sternberg forms. And of course, we don't typically see a Hodgkin lymphoma in the brain. That doesn't really make sense. So we know that this is probably an immune suppression related process. And she actually did extremely well, withdrawal mycophenolate, rituximab monotherapy, and it just resolved. And actually her granulomatosis also improved, and she was no longer needing any immunosuppressive therapy, and no evidence of recurrence after several years. And this was actually seen in multiple patients that was previously published. This was a series from the Mayo Clinic. Other studies have been published as well, kind of recognizing that, hey, we are seeing a few more autoimmune disease patients also taking mycophenolate, appearing with these primary CNS EBV-driven lesions. They seem to behave a little bit better. Potentially it's because they can easily peel off that therapy, that immunosuppressive therapy in patients with autoimmune disease as compared to patients with transplants. We don't really know, but they seem to have a very low mortality rate with the excellent response for rituximab alone, as compared to this high mortality rate we had seen in primary CNS PTLD in the patients, obviously, with the solid organ transplant. So it seems that we have some common themes emerging, but we can't just group everyone together. There's type, there's site, there's viral association, and clinical context that all are very important to consider. And so we wonder, okay, this was something that was a little bit of a project to find. Is there a way that maybe, are there other examples of this, or is this just kind of like a one-off that, okay, maybe, mycophenolate and cyclosporin have kind of this unique association with CNS lymphomas, but are there other sort of lymphoproliferations and other sites where, we should be thinking about this, that there are particular populations that could be an increased risk? And there is one very well-documented additional way that this occurs. As many of you may know, hepatosplenic T-cell lymphoma, extremely rare type of lymphoma, very deadly, very kind of devastating, very sneaky lymphoma, hard to diagnose, with just snaking around in the sinusoids of the liver and spleen, and here in this case in the bone marrow. But it was found that certain populations, this is kind of being seen where we hadn't seen it before. In particular, young men with inflammatory bowel disease who are being treated with thiopurines, such as azathioprine, with or without anti-TNF alpha therapy. And of course, we had a lot of other patients that were being treated with azathioprine, and a lot of patients with rheumatoid arthritis and other conditions that are getting anti-TNF alpha therapy. But we didn't see the spike in hepatosplenic T-cell lymphoma in these other populations. It was really kind of unique to these young men with inflammatory bowel disease. We don't really know why that is, but it does appear to be another characteristic situation where one may want to be well aware of this potential diagnosis and potential considerations for alterations in their therapy because of that. And so I think it is very powerful that the 5th edition WHO has now revised kind of the classification approach to say, hey, now we know we have a lot of emerging methods. It's not just transplant where we kind of have this evolution of different immunosuppressive medications, but these are being applied more broadly. And there are also other types of immune modulating therapies that are emerging and being adopted in various different contexts. And we can't just start making a chapter about, every single one and kind of having a different way that we describe the diseases and all of these different categories. And it's also very difficult to keep track of when these things might be occurring and what they might be associated with, because it's not been standardized to include this sort of additional information. I think people know, okay, if this person has a transplant, I really need to keep track of that. I need to mention it in, at least the diagnostic comment, if not in the top line, because it's, very important. But saying like, it's not just for a transplant, like we really need to think more broadly about, when we make a diagnosis of lymphoma, is this occurring in the context of a normal immune system, or has this patient received some sort of therapy or have an inborn error of immunity or other factors that we should consider in, how this disease is evolving or potentially how it should be treated. And so this, it's kind of a very simple change to the classification system. It's like, rather than be specific to PTLD, we're just going to have a 3-part system where you tell the morphology, which we, always do, tell the viral association, and, address whether or not we think this is emerging in any type of immune dysfunction. And so that's about it. And the only thing that I think created significant controversy was the question as to whether people would misinterpret this to say that, okay, then all of these morphologies, regardless of the clinical context, should have the same behavior. And that's certainly not true. I mean, as we saw with the CNS PTLD versus CNS involvement following mycophenolate treatment in autoimmune patients, they seem to behave biologically very differently. We have very different outcomes in these cases, and your management may be very different too, because if you don't have a transplant, it's a lot easier just to remove immune suppression. So it's basically just a method of keeping track of these, not to say that it's going to be differences in management, not to say that they're going to have same outcome, nothing like that. And the WHO specifically mentions that you can include PTLD as an addendum, or, also include that as far as your diagnosis. And this is just kind of an alluvial plot here that is from their initial release of this change in documentation. That kind of shows how these processes are going to be reorganized into the new system. The ICC is, and interest of disclosure, I have worked with the ICC team on the chapter regarding this. I mean, it largely retains that structure from the 4th revised edition of the WHO, but it does go on to recognize that it is important to say this polymorphic category can be seen across settings. And so that is also recognized. And I think that's very important because there are various kind of lymphoproliferations that don't fit well into a diagnostic category of lymphoma that can be seen in these settings, and that allows us to better keep track of them. And so here's one that's also in the brain of a patient with HIV. So in the setting of the WHO, you'd call this polymorphic LPD, EBV positive, HIV. In the ICC, I guess you'd call it EBV positive polymorphic B-cell LPD, not otherwise specified. So basically the same. I don't think there's any confusion there. So another setting where this kind of revision to classification, I think, does come in handy is with EBV positive marginal zone lymphomas. These are specifically included in the 4th revised edition. They start being recognized as a form of PTLD, kind of more indolent form. And this is one that's actually involving the kidney of a patient with a renal transplant. She ends up having an EBV positive marginal zone LPD here. But they can be seen across immunodeficiency settings, and they seem to have a fairly similar course, fairly indolent course, but it's not restricted to PTLD. Autoimmune disease, inborn immunity, HIV, chemotherapy related, etc. And immune senescence, which can be seen in combination with chemotherapy and treatment for autoimmune disease. The other thing I will quickly mention, which I also think is an advance that's included in the WHO Heme 5, is recognizing kind of a more central role of EBV in lymphomagenesis. Like sometimes it has been kind of a more of an afterthought. Just like, okay, well, these processes are similar, for style points, you can mention, whether or not the Hodgkin's EBV related or not, is the Burkitt EBV related or not, but kind of changing our framework of how we think of these, at least beginning with Burkitt lymphoma, where kind of Burkitt lymphoma, we've classically thought about it being 3 epidemiological variants that vary in their association with EBV. For example, endemic Burkitt lymphoma, virtually all of those are EBV associated. In sporadic cases in adults, we kind of see maybe 20 to 30% association. And even in immunodeficiency associated, particularly like HIV, we're only seeing a subset of those, around 25 to 40% of cases being EBV positive. But we still kind of think about it typically within those categories. But it turns out that the biology and the mutational profile underlying Burkitt lymphoma may be a little bit different between EBV positive and EBV negative, and that may be relevant for therapy. First off, of course, we recognize that Burkitt lymphoma, kind of the hallmark is that MYC translocation, but that MYC translocation is not specific, and it's also not sufficient. We also see kind of a distinct background of mutational changes, with MYC itself being kind of the most mutated gene, and then in sporadic cases, we see frequent loss of ID3 or TCF3 transcription factor, which is negatively regulated by ID3, but we don't really see these ID3 and TCF3 mutations very often in the setting of EBV. That seems to be relatively mutually exclusive. And instead, the EBV kind of have like fewer driver mutations, suggestive that the EBV itself kind of is driving part of the tumor, and fewer mutations associated with apoptosis, along with the setting of kind of increased somatic hypermutation. So this kind of creates a scenario where there may be certain therapies that EBV-driven Burkitt lymphoma may respond better than, for example, a sporadic case, which tends to have more defects in apoptosis and p53 mutations. So that's now recognized that maybe, in the WHO-5 that we should recognize not just based on epidemiology, but based on EBV positivity, and these may form discrete biologic groups. And this may be something that we're able to recognize more broadly across contexts between EBV positive and EBV negative, possibly EBV hit and run cases as well, as we get more potential to identify those, and experience with those may also have distinct features that may benefit from alternative therapies. So just briefly, I think other herpes viruses, as we mentioned, can also play a role in the setting of immune deficiency, particularly Kaposi sarcoma herpes viruses, HHV8 in the setting of HIV most commonly. And these are also recognized as part of this post-transplant and immune deficiency dysregulation spectrum. The ICC notes that you can see rare cases where you have kind of follicular hyperplasia or abnormal follicles where you're seeing KSHV, and these are extremely rare, but should be called KSHV, HHV positive dermatrophic lymphoproliferative disease. And that disorder is also considered within the WHO as a variant of an LPD of varied malignant potential. Sorry. Interestingly, the KSHV, HHV positive multicentric Castleman disease is also considered within this immune dysregulation dysfunction system as a form of hyperplasia as well. And this is an example of HHV positive multicentric Castleman disease here, where we can see twinning occurring. Lymphomas qualifying as monomorphic proliferations that are HHV positive also occur in the setting, of course, more often seen in the setting of HIV, HHV positive DLBCL, or primary fusion lymphomas, but can also be seen in the elderly as well. HHV6B, as I mentioned, I think also is potentially interesting. This virus is fairly ubiquitous. Most people have been infected with it during early childhood, and it does reactivate in the post-transplant setting or in the setting of immune suppression and causes complications, particularly in bone marrow transplant, for example, and may be related to graft versus host disease. We don't, as of yet, know its potential role in PTLDs. This is an area that would be emerging and is not yet well researched, but I think is potentially interesting because its additional effects. It's a T lymphotropic virus, alters T cell function, particularly CD4 positive T cell function, and it is reactivated in the background of certain T cell lymphomas on rare occasions. But our experience with this virus is more limited compared to that of EBV and Kaposi sarcoma virus thus far in this setting. But I think it is an emerging area of potential interest. So in conclusion, all right, I always run over, so I apologize. We're almost there, though. It's 1 hour, so not bad. So in conclusion, I mean, I hope I have given you some background of interest on post-transplant lymphoproliferative disease, as well as lymphoproliferative disease in general that are arising in this immune deficiency and dysregulation setting. It remains a very complex area given that it's immune system cancers arising in the setting of an abnormal immune system, and a constantly evolving area, which I think makes it very exciting because of all the different ways that we have to manipulate the human immune system, basically for the benefit, overall for the benefit of patients with this rare complication that may occur. And I also wanted to emphasize throughout the talk that the most effective treatment strategy really kind of requires a synthesis of a lot of clinical data along with your morphologic data and increasingly molecular data as well. And I think that the 3-part standardized reporting system using this morphologic pattern, mechanism immune suppression, and viral association will ultimately enable us to kind of better recognize potential complications, even if rare, that may affect certain patient populations and allow us to better tailor therapies and also design immunosuppression regimens to minimize those type of complications going forward. So if happy to try to answer any questions, or of course you can always find me on Twitter or and many other ways online as well. We also have a couple books, Survival Guide to Lymph Node Pathology, I think addresses these topics very well and kind of more detail into the molecular aspects, into this beautiful text that I just came out from a huge team of folks edited together with Dr. Logavi. Highly recommend that book as well. WHO book is out and ICC book is coming, and I think it remains an exciting area for debate and discussion overall. So thank you again for having me here. Really thrilled to be part of this series.
Thank you so much, Dr. Crane. This was amazing. Thanks a lot. And there are a few questions I see online.
Okay.
So the first question is, does EBNA2 has a major prognostic role rather than EBNA1?
Yeah, I mean, I think EBNA2 is a very fascinating gene. It's certainly involved in kind of mitochondrial biogenesis. It is a transcription factor, basically goes into the nucleus, and I think can have a fairly profound role on cell function. EBNA1 has a more subtle role. It's required for kind of tethering of the virus, so you can basically, every cell that divides is going to go ahead and take a copy of EBV with it. So it's certainly, EBNA1 is certainly functionally required, although its role in oncogenesis is less. There's some thoughts that I believe may cause some DNA instability and other factors like that. But yeah, I think we don't really look at EBNA2 as much or yet, and it's in a minority of EBV-driven lymphoproliferatives that we can actually detect it by IHC. But I think that very interesting question, very interesting area for further study.
Thank you. There is a question from one of our colleagues at City of Hope, Dr. Soma, who has this question: when considering non-destructive PTLD, is there a size criteria to consider lymphadenopathy a mass?
That's a good question. I think that I guess technically, I don't think I have seen a definite size criterion. I mean, I think it would have to be recognizable as a mass, like either endoscopically if you saw something, or that you had imaging and you could actually appreciate it being a mass. But it's a little bit of a soft criteria. I mean, I think again, also the treatment may be relatively benign as well. So yeah, it's some of these I think that we see are a little bit incidental, because whether or not you have EBV association with a hyperplasia, is it going to be materially different than an EBV negative hyperplasia in that setting that you should really handle differently? It's a good question, though. I think I may we have to ask the higher ups what the cutoff is, but yeah, I think it's kind of a gray area of, am I really into a lymphoproliferation, and the less the mass you have, probably more gray.
Right. No, thank you, Dr. Crane. So the next question is routine testing for EBV latency, like LMP1, EBNA2, etc., recommended for all EBV positive immune deficiency associated lymphomas and lymphoproliferative disorders? Or do they have any clinical significance, prognostic significance, etc.?
This is a very good question. I mean, I think that is an area of debate, and certainly even amongst our own group here, I think some people are more attached to and more used to using these markers than others. I think in the setting of, when you have a kind of a question, is this a true Hodgkin lymphoma versus more of, kind of a, maybe it's immune suppression related, or maybe it's angioimmunoblastic T cell with Hodgkin-like cells in the background. I think if you see a broader array of, markers being expressed, of viral products being expressed, you're like, okay, this is not really a regular Hodgkin. I'm dealing here with some sort of immune suppression in the background. Now, say you've got like EBV positive DLBCL, and there's been some controversy about that too, whether or not, you're typically going to see latency 2 or latency 3. Does it matter? Maybe. I think at the moment, probably not. It's probably not critical to kind of to tease that out. Or maybe you just have EBR. Do you have, and you have a few LMP1 positive cells? Is that adding to your management? I'm not sure. Going forward, things like LMP1 are actually on the cell surface, and they're potential to target that. So I think going forward, there could be ways that it is actually important to kind of think about what's driving this tumor. Maybe there's specific inhibitors that would be of use, or CAR T cell therapies that target viral antigens are also being used as part of at least clinical trials in some instances. But routinely, yeah, I think routinely the only thing I really use is if there's a question of whether or not there's immune suppression background versus its true classic Hodgkin lymphoma, I think is the clinical utility of it at the moment. But
right, I think there's another question that is HSV-8 testing also recommended on all EBV positive lymphomas or LPDs in immune deficiency setting or HIV positivity?
wait, sorry, could you repeat that again? Is HHV-8?
I mean, is HSV-8 testing also recommended on all EBV positive lymphomas or lymphoproliferative disorders in immunodeficiency setting, including HIV?
I think no. I mean, I think you certainly could. It's fairly rare, actually. It's fairly rare. So I think if you have a patient with HIV and certainly any Castleman-like features, definitely you want to look for HHV-8 in that setting where you have kind of unusual plasma cell proliferation or plasmablasts or plasmablastic type, proliferations that are seen within a specimen that would be useful to do that. In the post-transplant setting in general, it's fairly rare. Extremely rare. The only time when I kind of really bring up the specter of kind of thinking about a primary effusion lymphoma, well, obviously you have an effusion. A lot of the cases are actually not effusions or may have an effusion at some desynchronous time. But if you have really aberrant marker expression, if you really have lack of, you're really not getting good B cell markers, you really don't know what it is. Like, sometimes these things can have just like MUM1 and maybe 1 or 2 other markers. And so if you're really don't know what it is, you're in an immune suppression setting, then HHV-8 can be extremely useful in that setting to make a diagnosis. But if something's like a more typical, has a solid B cell program, patient is a regular post-transplant patient, your utility of HHV-8 is pretty limited in that setting. And I don't typically see like EBV, even if you don't have a lymphoma and you test an HIV patient, you usually typically see some background. You could see occasional positivity. HHV really don't see much positivity usually without, really a higher suspicion. So yeah, I think it's probably not. And HHV-6 too, we actually don't really know what marker to test. What is the best way to test that yet? That could be doing something in the background more often than we realize. But with HHV8, it's actually LANA1 is similar to EBNA1. It tethers the virus to the DNA, and so that should be in every cell, and it's much more detectable than EBNA1. So I don't think there's anything that we're missing. In other words, like I think we're doing a pretty good job of detecting HHV8 when it's there, and it's pretty uncommon. Yeah. Any other questions?
Here is another one, Dr. Crane. Are there any specific criteria for immunosenescence?
That's another, I mean, as we all get older, I guess immunosenescence was like 50 at one point. Now I don't know where we pushed it back to. But I think that's a very important question because that's a very nebulous area that, a large fraction of our patients could fit into. And so do we say, because lymphomas tend to be more common in older patients, then do we just, basically all the lymphomas that we see are now going to be in this immune dysregulation, dysfunction kind of spectrum? And yeah, I think that remains a controversial area that I unfortunately cannot provide a specific answer to, but I think would be an important topic for like a workshop and thing to kind of think about whether or not there are like, things that we could specifically measure about someone's immune system to be a little bit smarter about this.
Right, thank you. There are two related questions, and you were talking about changes in WHO for PTLD. So the first question is the classification of PTLD, different subclassifications, are they still relevant? Number one. And the second, if they are relevant, how the different categories influence prognosis or treatment outcome and clinical outcome, etc.
Yeah, so the same categories remain very relevant. So basically we go back, I don't know if you can see the screen still, but so it's kind of the same things we're thinking about, the hyperplasias or the non-destructive type, polymorphic, specifically calling out, we add in mucocutaneous ulcer, and then is it a lymphoma also in those things. So those kind of same things that we were doing before remain relevant. And even more so, like, kind of thinking more carefully about how exactly do we define kind of what are the morphologic features and then put them together with viral association and the immune deficiency setting. So I think it's a little bit more clear now, or a lot more clear now how to handle rather than having, specific diagnoses that are different for each different setting. And that's my take on it, which I will say, because I'm not, I don't speak for the WHO. I mean, I'm just reading the WHO, similar to everyone else, in that regard and being part of these, but that's my take on the WHO. So if I need to be corrected, please do so.
And thank you. There is another one. Is there any cutoff like percentage for EBV positive large cells in immune deficiency associated lymphomas?
Yeah, so I mean, I think this is a tough question too, because I think if you just see scattered cells, then that's kind of, you can always have some immune suppression, maybe in the setting of a lymphoma or in the setting of, you have HIV, and then a separate lymphoma, and there's just scattered positivity. So you like to see that the majority of these large cells are actually positive to make, if this is a question, to make the diagnosis of EBV positive DLBCL. And the marker that you should use for that is always EBER if you can, because the EBER is a non-coding RNA that's seen in all the latency patterns, whereas you may see only a very minority of the cells, unless it's Hodgkin lymphoma, which you should see all of the Reed-Sternberg cells being positive for LMP1 and sending immune positivity. But otherwise, it's kind of a mixed bag where you're only going to see, each of these cells kind of very heterogeneous and may have a different expression pattern of LMP1 and or EBNA2. So, but yeah, you want to see that it's in the majority of these large cells to make such a diagnosis.
Right. I think one last question again, Dr. Crane, that how immunosuppressive therapy influence the progression of the disease, of PTLD especially?
Yeah, no, I think that's a very interesting question. I mean, I think for one thing, we saw, with the mycophenolate and calcineurin inhibitors, that it could affect kind of the propensity to get a certain type. There's also certain, medications that affect T cells, where you can get very profound increase in PTLDs. But then once you have a PTLD and you're on, typically people are on a multi-drug regimen, a decision has to be made, like whether or not they're going to revise that and how to revise that to most likely preserve the graft and give the patient the best chance of fighting off that infection. And I think that's an emerging area that is exciting. I mean, I think based on the data that we have from the primary CNS PTLD suggests, and in fact, Hopkins did revise how they're handling these cases. Like, you definitely are going to want to pull out mycophenolate in that setting and add something else. And so I think that's an area that's evolving, like how that is managed. But most typically, if a patient develops PTLD, for example, particularly polymorphic, you're going to want to somehow tone back the immune suppression, give the immune system a chance to fight it off, particularly if you've got multiple viral antigens going on or multiple different, kind of proliferations cropping up, that patient may respond very well to restoration of immune function, that, then the immune system can then take care of all of those proliferations. But I'm just a pathologist, so we have to talk to, the clinicians who specialize in this, but I do find that to be a fascinating area as well.
Right. I think these are all the questions that I found online, Dr. Crane. So, and thank you again for covering this very specialized topic and in such an informative and with a lot of breadth. And thanks for answering all the questions. And we would like to thank all of our viewers for joining the session. And Dr. Crane, there were a lot of viewers who joined from different parts of the world, including Italy, Brazil, China, India, to name a few. And there were a lot of residents who joined from Jorhat Medical College in India. And thanks to all the residents for joining. And don't forget to follow Pathcast and all the lectures that you can find them on Facebook. You can subscribe to our YouTube channel so that you can stay tuned with the upcoming lectures and also all the archive lectures. And we are also on Instagram, so you can find the lectures there and some reels as well. And you can follow Pathcast on X. And here is a barcode you can scan and get access to the online platform. And thanks again for following. Our next lecture is coming up. Actually, we are also having a lecture series on digital pathology, and this would be the 4th lecture in that series. And we will have Dr. Eric Wack from Path AI. He is going to talk on importance of AI fluency in today's era. And this is going to be on August 27th, next week. So hope to see you at that time. And thank you again, Dr. Crane, for joining us today. Thanks a lot.
Thank you for having me. Thank you everyone for coming. Appreciate it.